Hi everyone, Dr. Peterson here with Regions EMS for today's COVID update. Today is Tuesday, March 31st, 2020. Information presented in this video is current as of today. We make no guarantees for what happens tomorrow, as this information is changing daily depending on the topic. As always, refer to our website, regionsems.com. Click on the COVID link for up-to-date information. We will keep the date updated on that page so you know that the information is current. There's a number of resources there, including a frequently asked questions section. So if you're concerned about an exposure, if you're concerned about PPE, have questions, go there first, and then feel free to contact us if you have any additional questions. regionsems@healthpartners.com. A little bit of situation update for today. Currently worldwide there are almost 810,000 confirmed cases and almost 40,000 deaths. Again, the number of confirmed cases is likely higher than that because we're not testing everybody, but that is the data that's available. As of yesterday evening, the CDC reports in the United States we have almost 141,000 cases with just over 2,400 deaths. Minnesota today, 629 confirmed cases out of about 20,000 tests and 12 deaths. Wisconsin is about double the number of cases, 1,221, and they've only tested about 15,856, and they have 14 deaths. We're still probably a couple weeks away from the peak, but again, models are based on very limited data, and it's all theoretical at this point. We just don't know enough about this virus to predict this accurately. Current state, again, just a reminder, we are in contingency phase. We are starting to modify some of our responses, but we should still, as our resources are not overwhelmingly stretched, we should still be providing our usual standard of care to all of our patients. Again, Regions Hospital, some of the workflows there have been modified as far as trauma team activations, cardiac arrests. Most of the resuscitations will be occurring in Alpha Pod or Charlie Pod in the negative airflow rooms rather than Echo Pod. So just be aware of that. And again, a reminder, ECMO has suspended their operations outside of the University of Minnesota. So you can still call the ECMO team with an ECMO patient. However, you will be redirected to the University of Minnesota for the possible intervention there. Then finally, for those of you who are leaders in your organization, worried about what to do with symptomatic staff, send them home, how long do they need to be out, who gets tested. We do have some guidance on our website for testing of symptomatic first responders, a nurse triage line with health partners that we have been working very closely with them to prioritize first responders to get tested, especially if you're symptomatic. We also have worked with our occupational medicine department at Regions Hospital, and we do have some guidance on risk exposure, risk stratification, and what to do about possible exposures, who needs to be quarantine tested, monitored at work, that kind of thing. Obviously, we cannot overrule your own HR departments or your own OCMED providers, but please feel free to reach out to us if you'd like more information on that. Today's topic is Conserve resources, and we'll be talking specifically about PPE as well as our own EMS resources. So again, PPE supplies, you'll hear this day after day, are critically limited. We're worried about N95 masks. We're worried about face masks. We're worried about gowns, all of this stuff. So we need to be mindful about what we're using and when we're using it. Current recommendations are to wear a simple surgical face mask along with eye protection, gown, and gloves for a suspected COVID patient. If you are involved in an aerosol generating procedure, however, you should be wearing an N95 mask or higher. Aerosol generating, again, includes intubation, oropharyngeal suctioning, any airway device placement. CPAP is a big one, and then neb treatments we're including in that as well. We do have some of the viral inline respiratory filters that can be attached to a neb kit or a BVM to help filter out the viral particles that are being generated and expelled throughout the air. And I know that some of you have access to those as well. If you're having trouble getting your hands on those, please reach out to our team and we can assist in whatever way we can. Masks, the current guidance is that masks can be reused throughout a shift. Your HR, your EOC for your agency or your city may have different policies on that, and obviously they would supersede what we are recommending, but currently it's okay to reuse both simple face masks, goggles, and an N95 mask throughout a shift across multiple patients, as long as it is not visibly soiled or damaged. And just a note on that, be very careful when you're doffing your PPE that you're not grabbing the surface of the mask and contaminating your gloved hand, or hopefully not your bare hand, because then that would potentially spread possible particles to other things that you would then touch. But the masks can be reused, just take good care of them. What else? Some facilities, we have heard, may begin requiring PPE in order to even enter the ED. So you as pre-hospital professionals, you may be asked to put on a mask, eye protection, and gloves while you're bringing in a patient to any ED, regardless of whether or not your patient is under consideration for COVID-19. If they are, then you may be asked to specifically wear an N95 mask. We are hearing this from several organizations. Just be aware of that. Obviously, we want to be mindful about the PPE that we're using, and so don't gown and glove and mask everybody up to go inside of an ED if it's only necessary to send one person in with the patient to perform the handoff of care. We have to get a little bit creative and flexible in these situations, but just be aware of that. We are looking at encouraging some non-transport or alternative transport options for low-risk patients who are only seeking evaluation for COVID-related concerns. Once our resources do become stretched, then we may expand some of that. But for now, if somebody has stable vital signs, which means you do need to get a full set of vital signs, they're not in any distress and they don't have any other concerns, it would be appropriate to ask them if there's any other way that they could get themselves to the hospital or the clinic for testing. Preferably, we're routing people to clinics, or we're asking them to call their agents, their healthcare organization's nurse triage line for guidance, because many of these people are not being referred to the ER, they are being referred to clinics for evaluation and possible testing. You can always contact medical control through MRCC for any assistance with making a transport or non-transport decision on scene. And then separate from PPE, I know the cell phone networks have been a little bit spotty as everybody's home and using cell meetings and phone meetings and that kind of thing. So try to use your radios as much as possible, especially when you're communicating with MRCC. I think you'll find the radios to be a little bit more reliable right now than the cell phone networks. And then also we are temporarily suspending the need to call in non-transport reports to MRCC for the low-risk patients. Obviously, they're really young infants. Anyone with significant comorbidities or anything you're concerned about, we still want to call that in because we can assist with getting a doc on the line to help you make that decision. But for the low-risk routine stuff, you don't need to call in MRCC. All right, so let's go to our daily trivia question. Yesterday's question was, why was the Spanish flu named after Spain when it killed millions of people worldwide? Excellent question. The answer is that although Spain was one of the earliest countries where the epidemic was identified, it was during World War I era, and there was a lot of wartime censorship occurring throughout the world. So Spain was a neutral nation during this war and did not enforce strict censorship of its press, which likely led to earlier published accounts of the illness out of Spain compared to other countries where the press was being censored. People falsely believed the illness was specific to Spain, and the name Spanish flu stuck. It likely originated actually in North America. There's some consideration about even Kansas, some military regiments in Kansas. That may or may not be true, but later the virus was determined to actually be the H1N1 strain of influenza. So I'm sure we've all heard of that. Shout out to the people who submitted answers for yesterday's question. I had several. We had Michael from Roseville Fire, Chief Pritchard from Cottage Grove Fire, Brandon from Oakdale, Tracy from Anderson Windows, Tim from Baldwin Ambulance, Chief Glazer from Stillwater Fire, Maureen, and I didn't get your agency, Maureen, so I apologize for that, and Wade from Lakeview EMS. So congratulations to all of you. Thanks for engaging with us and bringing a little bit of friendly competition and fun to this otherwise kind of bleak outlook for the next several weeks, if not months, that we're facing. So moving on now, today's trivia question, and again, if you think you know the answer, please email us at regionsems@healthpartners.com with your best guess, and we'll give you a shout out tomorrow. Question of the day: which is the best way to control the spread of the novel coronavirus COVID-19? Is it donning, doffing, or dabbing? And with that, I will leave you to your day. Thanks for watching. We'll see you tomorrow.